Abigail, an 86-year-old woman living in a nursing home, is brought to the attention of the medical staff because of her lethargy. Relatives note that she has been unable to recognize family in the past week. Her medical history is notable for Alzheimer's disease, osteoporosis, and hypertension. Her medications include memantine, donepezil, alendronate, and hydrochlorothiazide, the dose of which was recently increased. The patient is sleepy and oriented only to person. CT scan of the head is unremarkable. Laboratory testing is notable for a sodium concentration of 122 milliequivalent per liter and normal glucose levels, renal function, and hematocrit. What is the most likely diagnosis? Hyponatremia, which is more prevalent in the hospital setting or in nursing homes. The causes of hyponatremia are often categorized clinically according to volume status. Hypovolemia, renal losses or gastrointestinal losses. Euvolemia, syndrome of inappropriate antidiuretic hormone (SIADH), hypothyroidism, adrenal insufficiency or primary polydipsia. Hypervolemia, heart failure, cirrhosis, or some cases of nephrotic syndrome. What symptoms are typically associated with this condition? In the most cases of hyponatremia, we face a decreased osmolarity. It causes an osmotic water shift that increases intracellular fluid volume. Clinical manifestations are typically neurologic in nature, secondary to cerebral edema within the confines of the cranial vault. Non-specific symptoms such as malaise or nausea are common. Headache, lethargy, confusion, and obtundation may appear as sodium levels fall further. Stupor, seizures, and coma can occur if the progression is rapid or concentrations fall below 120 milliequivalent per liter. What is the pathogenesis of this condition? This patient is likely suffering from diuretic-induced hyponatremia. Thiazides block sodium reabsorption in the distal tubule, resulting in renal losses of sodium and water. The resulting volume loss stimulates ADH release, which enhances water reabsorption in the collecting duct. Thus, while there is net volume loss with the diuretic, some water is retained and sodium concentration decreases. If hyponatremia develops over a period of days rather than acutely, the brain cells adapt by secreting salts and, over time, organic osmolytes to prevent excess water entry and swelling. This may explain why no significant swelling can be seen on CT scan of the head. What other laboratory tests will help to identify the etiology of this condition in this patient? Plasma osmolality, urine osmolality, fractional extraction of sodium, urine sodium concentration, and urine potassium concentration are helpful. If diuretics are responsible, as in this case, the plasma osmolality may be slightly low. Urine osmolality is elevated, as thiazides stimulate antidiuretic hormone. Urine sodium is elevated because of a thiazide mediation decrease in reabsorption. However, some of the excess sodium delivered to the collecting ducts is reabsorbed at the expense of the potassium. Urine potassium, therefore, would also be elevated. Treatment should include discontinuing the thiazide, and because the patient is symptomatic, sodium should be replenished with isotonic saline. In cases such as acute seizures, hypertonic saline should be used, but care must be taken not to correct the hyponatremia too quickly. Rapid correction of chronic hyponatremia can result in central pontinomyelinolysis, a diffuse demyelination syndrome. A rapid increase in serum osmolarity leads to brain cell shrinkage, and this is believed to result in demyelination. If hyponatremia occurs suddenly over a few hours, then rapid correction is unlikely to cause demyelination, as the brain will not have time to undergo compensatory measures as we have discussed.